Untangling PANDAS and PANS is a podcast about two little-known medical disorders characterized by the sudden and dramatic onset of symptoms such as obsessions and compulsions, vocal or motor tics, and restricted eating behaviors, and a whole host of other symptoms following a strep or other bacterial or viral infection. I have the privilege of interviewing some of the top researchers and clinicians in this rapidly growing area, known by various names such as immune-mediated neuropsychiatric disorders, infection-associated neuroimmune disorders, and autoimmune encephalitis, or simply PANDAS and PANS. My name is Dr. Susan Manfull. I am a social psychologist, the executive director of the Alex Manfull Fund, and the mother of Alex Manfull, who died at 26 years old due to PANDAS, a disorder my husband and I knew next to nothing about, certainly not that our daughter could die from it.
This is episode 4 of Untangling PANDAS and PANS, recorded June 15, 2024.
Dr. Beth Latimer is one of the pioneers in the field of autoimmune encephalopathy before PANDAS was put forth in 1998 by Dr. Sue Sweeto and her team at the National Institutes of Health. One of her first patients that she treated in her neurology training was a young girl with Sydenham's chorea. That was in the late 80s. Dr. Latimer's early training was at Walter Reed Hospital, where she had 3 years in pediatrics and 3 years in neurology. Dr. Latimer was part of the group of clinicians and researchers who met in 2010 at the NIH to further define PANDAS and what came to be called PANS. Let's just say that it was an interesting time. And since that time, she has become one of the nation's experts on treating PANDAS and PANS. Her services are in demand across the country and around the world. We talk about those early days, as well as her work with adults with neuropsychiatric symptoms triggered by infection, underscoring why the P in PANDAS and PANS should disappear. Dr. Latimer currently has a private practice in Washington, D.C. She is also on the Scientific and Medical Advisory Board of the Alex Manfull Fund. We were very fortunate to catch up with her on the Cape, where she escapes to her happy place. All right, Dr. Latimer, let's get started. And I'd like to begin with a little bit of information about your early career. Can you tell us what piqued your interest in neurology and how you began your career as a neurologist?
Oh, wow, that's an interesting question. When I went to medical school, I planned on being a geriatric internal medicine doctor.
Oh.
And, you decide what you're going to end up specializing in as you do your rotations. I did internal medicine. I loved it. I did surgery. I hated it. I did pediatrics. I loved it. And then I did pediatric neurology as an elective my fourth year of medical school. For some reason, I thought that was important. And it just kind of went from there.
It just spoke to you?
Yeah, didn't want to do general pediatrics. I wanted to do a specialty. Mm-hmm. And I probably could have done other ones, but that's the only elective I took as a fourth year medical school student was pediatric neurology.
And that was it?
Yeah.
Excellent. And then can you tell us about how you began your career as a neurologist?
Oh, well, I was very fortunate to get a military scholarship to pay for medical school. So most of it anyway. So then I came to Walter Reed and trained for 3 years in pediatrics and then did a 3-year neurology residency. And then again, was very fortunate to remain at Walter Reed, mostly because my husband was running a training program. So I wasn't sent off. And then I finished up my commitment and, then I was discharged from active duty.
And you began a private practice?
No. I did not. It never even dawned on me that I could do that. So initially I went to Georgetown, where I was for 4 or 5 years, and it was wonderful. I had great experience. And then, the big company bought Georgetown, and I was the only one, and they weren't working there as a child neurologist, and they were not going to let me hire anyone else. So I really couldn't be on call every night. I did that for the first couple of years I was there, but I
Whoa.
just had the kids at home, so it was a lot. And I sort of got, an offer I couldn't refuse from another medical center for every fourth night, which turned out to be, I was there for 18 months, but from 7 in the morning till about 10 or 11 at night.
Ooh.
And I said, this job is too much. First of all, it's too much for me. And it was also, I felt like it was dangerous. That was covering too much. Mm-hmm. Mm-hmm. So then I went into practice.
Went into private practice.
Went into private practice, right.
As a pediatric
As a child
neurologist.
neurologist, right. Mm-hmm. I still took care of some adults then because my early interests in neurology were kind of focused on, believe it or not, Botox, but not for the reasons that people use it now. Uh-huh. Botox at that time was used for strokes, and we did some early studies at Walter Reed on cerebral palsy. So we could loosen up the tight muscles, and the kids could walk. We were one of the first centers to do them. It was really, really kind of cool.
Oh, I didn't realize
my
that.
early focus, expertise was really in spasticity management after strokes or brain injuries, and also on migraines, which I've always and continue to be interested in.
Interesting. So the work with strokes took you into maybe more likely a geriatric population?
No, well, because children have stroke. I mean, a lot of children with cerebral palsy have the same neurologic injuries. So in that area, I did take care of adults and children. Mm-hmm. Then the PANDAS world came knocking. When I was at Walter Reed and neurology training, I remember, I'll never forget this patient. We were making rounds, and there was a child, probably a 15-year-old, I'm guessing 13 to 15. I can still visualize her. She was lying in a bed with Sydenham's chorea. And we were making rounds, and I was like, okay, give her 6 months of steroids and 6 months of antibiotics, and 85% of the time this gets all the way better. And I remember thinking, well, what about the other 15% of the time? Mm-hmm. And that was also an interesting time in neurology because they were starting to treat the autoimmune diseases like MS.
Mm-hmm. So what year was this?
89 to 92.
Okay.
I was in neurology training. Mm-hmm. So they were starting to treat, maybe it was 88 to 91. I think I took my boards in 92. But they were starting to treat MS. There was like a progressive researcher who was starting to do injections with sandoglobulin, like an immune globulin, in the MS patients. And that's kind of when the whole immunology world kind of came in. It also came in while the neurology ward was right next to the AIDS ward at Walter Reed. So while we were trying these new treatments for MS and these autoimmune diseases, which frankly didn't work very well, but everything doesn't work very well. A lot of things don't work very well at the beginning. Mm-hmm. You learn a little bit. And the ward right next door was all these men dying of AIDS. And we had a call room right there, so we were with them all the time. Mm-hmm. And that's where we learned all about the immune system.
Oh, interesting. Wow. So
I didn't learn all about the immune system. That's when the world finally put a lot of money into learning about the immune system.
Okay. What a great education to set the stage for working with PANDAS and PANS. Because it seems to me like many doctors are not as knowledgeable about the immune system. And maybe that's why they stay away from autoimmune disorders and things as complicated as PANS and PANDAS. Well,
maybe so. But there are other autoimmune neurologic diseases that no one has trouble treating. Right? Mm-hmm. So there's, acute disseminated encephalomyelitis. That's when the kids come in after a virus and you do an MRI and all these white spots and they're paralyzed or they're in a coma and they can't wake up. You give them high-dose steroids. Everyone does that, accepts it as normal, and doesn't even think twice about it. Another example is transverse myelitis. Someone comes in after an infection and they've got a big white lesion in their spinal cord and they're paralyzed. Everyone gives them high-dose steroids. So because you can see it on the MRI, I think it's
that makes a difference.
And the exam is motor, and level of consciousness or seizures. You don't have any choice. You've got to treat them, right? Mm-hmm. But I think these pandas is not the most desirable term, but these patients with an infection, triggered, encephalopathy, which is inflammatory in nature, often have psychiatric symptoms. So I think it's unimaginable to many people that they could get better. Even I think sometimes it's still unimaginable to me. Sometimes when someone comes back in and they're better, I'm like, really? Or they've gone to a psychiatric hospital and they come back and I'm like, well, why don't they test everyone for Lyme disease when they go into the psychiatric hospital?
Yeah,
I'm
great
like,
question.
I don't know.
Wow. Okay, so when you started working with patients with PANDAS and PANS, so that must have been shortly after Sue Sweeto's paper.
Primarily, however, I didn't see one single child with Sydenham's chorea the whole 5 years I was at Georgetown. Not one. Mm-hmm. Well, when I went to this other medical center for a year and a half, it was a really busy place, like 150 pediatric beds, a huge ICU, a big NICU. I was in the clinic one day, and this child came in and had Sydenham's chorea. Walked right into my clinic. I looked across the room. I said, that child has Sydenham's chorea. That was before, private equity and insurers told us what we could do. So I admitted the patient to the hospital, gave her IV steroids, and 24 hours later gave IVIG, and the child walked out the door the next day perfectly fine. I do not believe that family knows anything like that, has any idea what was wrong with their child, because they were Hispanic, and my interpreter was not a medical person.
And so that was in the early 90s?
That was in 98.
98.
No, 96.
Okay.
Between 96 and 98. So when the NIH came out with the study in 98, I saw a sibling in my office of one of the children who had been in the NIH study. Oh. They're like, oh, my other son was in this study and he got plasmapheresis and he got better. Can you do it? And I said, well, it makes total sense, but I can't just do it. I have to talk to, my colleagues at Georgetown. We have to, and we had many, many meetings and everyone was like, that makes total sense. It wasn't even controversial. It's hard to describe that. It really was not controversial at the time.
You just saw the symptoms and you knew that they needed to be treated.
Well, we knew that there was an autoimmune process going on. We knew that the study had happened. And we also knew about the centuries-old history of Sydenham's chorea. It really wasn't controversial. I don't know how else to describe it except that it just wasn't.
Well, it still befuddles me as to why it is controversial. But let's talk about the very beginning of this. As I understand it, PANDAS was first identified in the 1980s, although it wasn't called PANDAS. It was called PANDAS, if I recall correctly. Sue Sweeto and her team there, of course, were not the first ones to identify, to look at Sydenham's chorea patients and recognize that some of those patients have a certain perseveration of behavior, which was what William Osler wrote.
In 1904,
yeah.
They have a perseveration of thought in a major textbook.
Right. So it's for that reason. I mean, and the fact now that there is so much research on this, it still befuddles me as to why it's so controversial. But if I recall correctly, she and her colleagues were looking at Sydenham's chorea patients, and they saw that something like 70% of the children there had psychiatric symptoms as well as the chorea movements, and most of those symptoms seemed to be obsessions and compulsions. So she went on and then in 1998 published the paper that identified PANDAS, pediatric autoimmune neuropsychiatric disorder associated with strep. Can you explain why that was initially defined as a pediatric disorder?
I think it was defined as a pediatric disorder because they were testing children. I don't think it's more complicated than that. I mean, Dr. Sweeto is a pediatrician. Yeah. She wasn't going to see the 40-year-olds,
So, when I was thinking about questions for you in this conversation, I read some of the literature a little bit more closely, and I saw that pediatric is defined as up to 18. even up to 21 by some people.
Well, it's defined up to 18. I think that's the real definition. But there's a lot of pediatricians who take care of kids through college.
So I'm wondering, it's called pediatric autoimmune neuropsychiatric blah blah blah, and yet the criteria suggests that it has to be prepubescent onset in order to be diagnosed. That's how it was initially.
Correct.
So I find that kind of confusing.
It's almost like any other disease. You identify what's in front of you, and then you realize that there's people outside this group that also have this. But the brain is really interesting. If you can have the same disease at 6 months, at age 2, at age 8, at age 18, at age 30, and the exact same genetics, the same disease, and it looks totally different at those ages because the brain's a different age.
Mm-hmm. So you're actually anticipating one of my questions. Does this disorder present differently, or how does it present differently as an adult versus children?
I think everything presents differently as an adult. You've got more coping skills. Mm-hmm. 3-year-olds, 5-year-olds who get OCD, the teacher tells them to do something and they throw a chair at them. A 30-year-old working in a bank is not probably going to try to go home. There's different ways of coping with OCD when you're 3 or 15 or, a working person. And so I think that's one of the big issues.
Mm-hmm. All right.
Even in the same individual, I've seen in the same person present as a 7-year-old with extreme rage and anger and destructive behavior, later present with OCD, and later present with RFID or eating disorder. Even the same person can look different with each flare.
Interesting. So let me back up just a little bit. When you first started treating PANDAS and PANS patients, did you start with children for the most part? Since
yes. Yes.
So how did it come that you started treating older patients? Did you recognize that, hey, this is not limited to children?
Well, it's as simple as this. The mother and the child come in, and you start taking the family history, and the mother said, oh, my brother in 7th grade wouldn't go to school for 2 years. And now he's on 3 medications and he's not working and he's still living with my parents. And we had a lot of strep. Or the mother themselves says, this happened to me in middle school and it eventually kind of faded away, but I'm still on a bunch of medication.
Wow. That must have been fascinating early on as you learned more about how this presented in individuals and families.
I have one family who was in the initial NIH study. And the mother is now in her late 30s and has 3 children of her own. And came in with the generation above her, herself, and her child. And the grandmother came in with an unbelievable family history of all these different family members with autoimmune nephritis and endocarditis and rheumatic fever, and it was an amazing family history. All these people went undiagnosed.
Interesting.
And it's not just strep. I mean, there's a lot of people who have had Lyme disease for a long time, or Bartonella, and they've been diagnosed with something else because Lyme is hard to figure out, and it's kind of acceptance is kind of cross country, kind of like the frontier people said. And you don't want to assume everything is Lyme or Bartonella, but it's real. And I've seen patients who were told they had MS for 20 years, and they turned out they had Lyme disease.
Wow. Yeah, it's amazing to me that it's not tested for more frequently.
Well, it is tested for a lot. on the East Coast for sure, and in other parts of the country, but the tests are not good. So even if you look at the tests from one of the standard labs, it'll say, there'll be a disclaimer. If you really think the patient has this, just go ahead and treat them. And the CDC is fully aware of that. And I think they were getting ready to sort of work on it until when COVID happened.
That's interesting.
We got sidelined again.
Okay, so the Susuito and team's paper came out in 1998 introducing this subject of PANDAS and the neuropsychiatric symptoms that surface as a result of strep. So you were involved in the group of clinicians and researchers in 2010 who got together to consider that there were other triggers.
Correct.
Right? Can you tell me a little bit about that meeting and the outcome of that?
Oh my goodness. Without getting into trouble. Yeah, it was not a particularly good time in my life, but I went to the meeting, and there were 50 doctors there. And
50?
50 neuropathologists, ethicists, neurologists, psychiatrists, infectious disease people, child neurologists. I can't even remember all the people. There was a lot of people in the room.
Was this at
It was at the NIH, right. And there was a lot of tomato throwing, a lot of yelling, and there was it could be contingent from like the Tourette's group who really didn't want tics to be involved with PANDAS. And I think for the most part, the people who were treating it were like, tics is the least of our problems. We'll take it out of the criteria, no problem. And we'll change the name from PANDAS to PANS without the tics, because there was this concept, I guess, that we could all write a paper together, a white paper, and I'll sign it, which did not happen, obviously. But we did take tics out of the criteria, and other people, there were other papers coming out that people saw it after mono or after, mycoplasma, whether that's even accurate, I don't know, because everyone has mycoplasma titers. I think some of these things are not really triggers. But so that was the agreement after a very, very, very long day. And the outcome was not the same. It didn't result in the outcome that we agreed upon.
Can you elaborate on that?
Well, they didn't sign off on the paper.
Okay.
And then another paper was written instead of moving from PANDAS to CANS.
Children.
Child.
Okay.
Yeah.
Instead of pediatric.
Yes. Anyone's welcome to read that paper and make their own, come to their own conclusions based on what was in that paper.
And so which paper was that? Was that...
Moving from PANDAS to CANS.
Oh, okay. Right.
You might want to look up the journal. That happened several months later when they were called out for not disclosing their financial interests.
Oh, that's very interesting. Okay.
Yeah. And a single line in the same journal.
Eventually, PANS was put forth.
Correct.
And that, according to this study, this paper that I have, that Susuito, James Leckman, and Noel Rose.
Noel Rose was the ethicist from Hopkins who chaired that meeting at the NIH.
Oh, okay. All right. And
he had to stand up and sort of take over because things were getting out of control.
What an interesting time.
Yes.
Okay. All right. So you decided on pediatric because, as we talked about earlier, that suggested that it could extend to, according to this paper, that it could the population that could be treated could extend to 18, maybe even 21 years old.
There was one other kind of sidelight to this, and that is that in the old days, like when I was in pediatric training, strep was a disorder of school-age children. That's what we were taught every single day. Don't test adults, don't test infants. It's an illness for school-age children. Adults didn't get strep, and babies didn't get strep. And Tourette's did not occur. Tourette's was the OCD with the tics and anxiety and ADHD, which is, and that was also not able to be diagnosed unless the symptoms started before pre-puberty. Or, so if someone came in with tics and OCD at 12 or 13, it was like, this is not Tourette's.
Okay.
So I think it sort of get categorized in the same way that Tourette's and strep had been categorized. Like, we all know that strep only happens in school-age kids, which was no longer the case because they stopped taking tonsils out. We all accepted that Tourette's had to occur before, in the previews. And so I think this was an attempt to transition Tourette's symptoms into like a medical explanation, with the presumption that these other assumed factors were true.
Well, it's very complicated. So right now, Tourette's is a separate syndrome, or a separate disorder, but tics are still part of the...
Definitely.
Right, the diagnosis for
Yes.
PANDAS, not PANS, but PANDAS as well, right? Okay, so it was taken out of PANS. Okay,
It was
that's
taken out.
interesting. All
It was.
right.
I think it was categorized. I think it was movement. There was another
Okay.
motor abnormalities, I think.
Oh,
Yeah.
all right. And then, so with PANS, it seems that even though it's called, I think, where are my notes here? Because this is where it gets a little confusing for me too. It seems, well, what it says here is because adolescent cases were not uncommon in clinicians' experience, the conference participants decided that the new syndrome should not exclude cases with post-pubescent onset, as the PANDAS criteria had done. So reading that line with regard to PANS, I again, since our subject here today is really about, eventually about adults and PANDAS, that would seem to me that this would be a diagnosis that clearly could be made for young adults. So again, I don't see where the controversy is about including young adults in possibly diagnosing them as having PANDAS, or rather PANS, which includes PANDAS.
Yeah, I think that we're dealing with sort of a false dividing line, right? Where like people don't turn 18 and their brain just flips into a whole different brain. It evolves. So it's just like, does Alzheimer's occur in 40-year-olds? Yes, it actually does. Like, And people would have said, oh, that doesn't occur until people are much older.
Well, I'm thinking back to a conversation that we had, you and me, had at NIMH, in which they insisted that PANDAS could not occur in someone who was in their 19 years old.
I think there were a lot of compromises at that time made to just get something established as a criteria that could be further studied. And I think that there was a lot of unknowns, and I think that was one of them.
So do you look forward to another consortium where some of these inconsistencies can be ironed out based on your clinical observations?
That would be very interesting. I would hope that it would include a lot of adult neurologists. I would hope that and that was another thing, there was not a lot of adult neurologists there, like solely adult neurologists. I would hope that it would also include some people who treated long COVID, who know that it can do this kind of thing to children as well as adults.
I just looked at the new definition, or the agreed upon and most recent definition of long COVID, and it could easily be mistaken for a PANS diagnosis.
Oh, I have several patients who have been symptom-free for over a decade and have come in with symptoms after either COVID or the COVID vaccine.
Yeah, I think COVID, as horrible as it's been, may turn out to have a silver lining for these disorders.
Oh,
like
absolutely.
PANDAS.
It has, like, look at it, not just the brain, it's the heart, there's a lot of things that causes inflammation post-COVID. I mean, we know that elderly people, when they get worse from a psychiatric standpoint, first thing they do is look for an infection, and they treat a urinary tract infection. It's inexpensive. Everyone agrees it's okay, and everyone is seeing it work. So it's not that shocking that an infection can cause an encephalopathy.
It's such a great example.
I think
too.
it's shocking that it creates the encephalopathy in the part of the brain that doesn't involve motor function or cause seizures. So people can look at it and say, they were probably like that all the time. Or no one noticed. And they're not in the hospital. No, really, who knows what they were like before? The family must just, this is wishful thinking, you know. So, but as unimaginable as it is, and I say this to families, as unimaginable as it is to you that your family member could have been fine and now has this serious psychiatric problem, it's equally unimaginable that they could get better, but it's possible.
I think people have to remember that.
Yeah.
I might have to play that part of this recording over again. It's really so important to know. So what do you have to say to doctors who tell their patients who are presenting with symptoms that look like PANS that they say, oh, you'll grow out of it?
I would say sometimes you do. Initially, people, the thinking in like 25 years ago, this is how long this has been going on. So initially, people would say, I dropped my child off, my perfect child with no history of any problems, and I picked them up from school, and I thought they had been molested. Like they were perfectly fine, and now they were like completely manic or clinging to me or screaming or couldn't sleep, incontinent, all kinds of things. And I think that was the original assumption. Unless you take a very good family, a very good history of the child, that's probably what you're going to believe. But often, if you really take a careful history or you look through the medical records and you see that indeed the child went in one day because they wouldn't go to school for like 3 weeks, or they were kicked out of preschool, or they were evaluated for frequent urination and someone thought they had diabetes but they didn't, or they couldn't wear socks for 2 years, or they went through these little bumps and then they had a big episode.
So
that's a more common situation than nothing at all was wrong until one day.
So I think those soft signs, for lack of better words, are really interesting. And I'd like to see some more research done on that, the prodromal period before the...
Sometimes they're not even soft. I mean, sometimes it's like he didn't go to school for half of kindergarten. I didn't know what was going on. And they're like, well, we moved, or the grandparent got sick, or the dog died. Or, there's all kinds of things going on in kids' lives all the time. So most kids don't have an ability to go to school for 3 months when those kinds of things happen. So people probably should pay a little bit more attention to that. Medically, not...
Right.
Yeah.
Yeah, that's really interesting. So we talked a little bit about the fact that adults have better coping skills, for example, than children, so therefore they're going to present differently. Are there any other ways that you found that they present differently?
Well, they're not as violent as some of the kids. The OCD can be just terrible. The eating disorders can be terrible. The sensory problems can be pretty bad. But an adult who can't stand the bright light and loud noises puts ear pods in and wears sunglasses and chooses their own clothes.
Yeah.
And if they don't want to wear socks or they don't want to wear a scarf or a turtleneck, they don't wear it. Again, I think there's a lot with the coping skills.
Do you think that adults are able to recognize or even anticipate when a flare may be coming?
No.
No.
Not
okay.
always.
Interesting.
Sometimes they will call and say, I can feel it coming back. But no, not always. And sometimes I saw a parent not too long ago with their adult child who I had kind of forgotten how sick she was because she was fine when she was in my office recently. And the mother described to me these really dangerous episodes as, she said, it's a suicide attack, like you would have a panic attack. It's like it comes, and unless someone is standing right there, they can't stop it.
They just get intrusive thoughts to engage in certain behaviors, or?
Oh, no. I've had children. I had a child who's slid off his roof jump out windows, run across highways. It's almost like they're not there when it's happening. It's like it's something just it's a disconnect.
Yeah. So, in working with adults, do you find, I'm thinking, I know what your answer is, but maybe you can elaborate. Do you find you have a better window into what's going on with them? Like maybe because they can express themselves generally better, that they can talk to you about any intrusive thoughts or dreams or...
Oh, yeah, the vivid dreams are a big thing. I still think sometimes the adults are too embarrassed to, like, you can't just tell me what happened. You have to ask very specific questions. Do you have scary dreams that you're going to die? Do you, have sexual intrusive thoughts? People are not going to volunteer that unless you ask them. You don't have to say, do you have sexual thoughts? Some of the things that are common with this are intrusive thoughts about religion, sexual stuff, death and dying. And if they nod, and a kid will do the same thing. That you don't need to know the details, but you just have to give them the opportunity to share that information with you.
How about the impact on their sense of self?
Oh, the adults, the young adults, like 20 to 30. This is a huge problem. It's actually even in the high schools. So if a child gets sick and starts to isolate, right? Because you really don't want to socialize when this is all going on in your head. Or you're not sleeping and you're sleeping all the next day because you're exhausted, or you're having trouble getting your work done and your processing is slow, so it's taking you a lot more time to do things. Or you've been home for a year or two trying to get better and your friends have moved along without you. That's not a normal thing for people that age to experience. And it's very isolating and depressing and creates a terrible sense of hopelessness.
And that leads, I guess, to the question in terms of treatment, that I think that you, as you said, you can treat the condition and the symptoms may be gone, but do you find that it would be valuable to have therapy to deal with the fact that they have had this, that they lost 5 years of their life or longer?
Or longer. Some kids don't remember their childhood. I think sometimes some kids benefit from therapy, but a lot of the time they don't remember a lot of what happened. So therapy is like they're trying to explain what happened, but they didn't even make new memory, so they really don't know how they got where they got. So I'm not sure that helps as much as like moving forward therapy.
Right.
Like there are several kids who've been like home, like bedbound because for some reason they've got motor problems, and or they've been sick in the house for a long time, and that is very deconditioning. And in those cases, getting them a personal trainer, getting them into physical therapy. Sometimes the kids who've been out of school, get a gap year going on. Like maybe they do something for a while where they go out and they reconnect with people, or connect with new people, develop a new friend group. And anyone who's doing anything with this condition, I don't care if they're going to school for lunch and art, anything they're doing, anything they are able to do, they should keep doing. Stay connected, however they can stay connected. It makes just a gigantic difference.
All right. So do you treat, we've talked a little bit about this as well, so do you treat adults
Yes.
any differently? Can you talk to me a little
differently?
bit?
Yes, probably a little bit. Because the earlier someone is diagnosed, whether it's Lyme, Bartonella, strep, staph. I've seen staph. Like, a lot of people have staph in their noses. The earlier you get them, treat them quickly, they're going to get better quickly. Someone who's been sick for a long time, it's like you haven't been immunized like over and over and over again. The immune system has a lot more memory, and it takes a little bit more effort to get rid of it. But sometimes, surprisingly not. I mean, sometimes adults have been sick for a long time, and you treat them once, and they're like, I'm good.
Do you understand why that would happen? It's so interesting. There's so much more to research.
Unless perhaps we've identified an infection that no one knew they had for a long time. Mm-hmm. And again, I keep saying Lyme and Bartonella. Bartonella is a virtual epidemic in this country right now. I don't know why. I mean, no one really knows where Lyme came from either.
And the fact that it's spread so quickly. And I think Bartonella in particular, I don't know if you had a chance to read Shannon Delaney's.
I did have a chance to read that, yeah.
That's pretty amazing and would certainly suggest that we should be have better tests and tests more frequently when someone comes
Everyone
in.
needs to be checked for Bartonella. And I have to tell you, I am shocked. I did not know how many people had cats. So, which is what you can get Bartonella from cats. I've seen it from cats, I've seen it from lice, I've seen it from tick bites, and probably other things that I don't know where the trigger,
House spiders, she mentioned.
Right. But I had a mother and son pair who got it from lice at the same time. But if you, I asked do you ever had a tick bite? Do you camp? Are you in Boy Scouts? Like, do you go into the woods? Do you have cats? A lot of people have cats. Like 30% of people have cats, I think. It's got to be at least that high.
Mm-hmm. Mm-hmm. So in treating them differently, the IVIG, is that administered any differently, more frequently, higher dose?
Not a higher dose. I mean, IVIG, after you've had something for 10 or 15 years, unless you're immune deficient. Mm-hmm. If you're not immune deficient, absolutely. It boosts your immune system so you stop getting sick with things that are triggering you. And it works great in that situation. I think when people have been sick for a very, very long time, you have to do a lot more investigation to think, like, what is the underlying infection in here that could be causing this that hasn't been identified. And I think more immune suppressive drugs work better than IVIG.
So rituximab, for example?
Rituximab, which is not FDA approved for this condition, although it is for other forms of autoimmune encephalitis. Mm-hmm. It's a very old and safe drug. Even, the other sort of run-of-the-mill rheumatologic drugs like methotrexate, mm-hmm. Naproxen, ibuprofen.
What about plasmapheresis?
Plasmapheresis is fantastic.
Now, why is it so hard to get?
I've actually identified 2 centers now that I can send patients to recently, but it's there's a couple reasons. One reason, one of the reasons is insurance companies are not paying for it, right? So you have to go with this whole. It's a whole big issue to find out if a hospital's got a contract with an insurance company and they're not going to pay them for that procedure. How do they do it, right? That's one issue. The second issue is that. There's 3 issues. The second issue is that it's not without any risk whatsoever. Mm-hmm. So when you're taking, your blood out and spinning it and taking off the plasma and putting back in plasma or albumin, your calcium levels can drop. You can get blood pressure can drop. You have to have a team that monitors this, right? And the third issue is that so many of these patients have such significant psychiatric issues that they can't get that treatment on a psychiatric floor or with psychiatric staff who could support them. They're on a medical unit. And the medical staff they don't have the psychiatric training to deal with an out-of-control, angry person who's suddenly going to pull their IVs out and run out of the building. And that may be the biggest issue.
That's a huge issue.
It's a huge issue.
Med psych beds, as they're referred to.
Well, it is a huge issue. I mean, we did 100 to 200 cases at Georgetown. And I had to send every child through psychiatry first to get like a rubber stamp that they were not going to do anything dangerous in the hospital whatsoever. And that's a pretty tough hurdle when it's not like, I want to try this medicine, see if it helps you. It's like, I'm going to put you in the hospital and give you a procedure that could be dangerous. Even with a child who doesn't have PANDAS, that's a little iffy.
Mm-hmm. Now, adults, though, it seems that
adults can be just as difficult and stronger.
Okay.
And the adult world doesn't deal with behavioral issues. Like in pediatrics, we deal with it all the time. This kid doesn't want his blood drawn. Okay, well, we have to draw it. If adult wants their blood drawn, they just walk out the door.
Interesting. So there's all sorts of challenges here, as we both know well. What about cannabis types of drugs?
There's no question that cannabis works for epilepsy. There's just no question. It works. It's used. People are getting it through dispensaries. It's still a federal crime, although it's legal in almost every state. There are doctors who have special permission to prescribe it and are become very educated about the different strains, etc., which I am not. I don't have a problem using it. It's out of my purview. It's probably a lot safer than a lot of antipsychotics and antidepressants.
Excellent point. So with adults, in terms of helping to diagnose and certainly in terms of doing research, there are procedures that can be more safely done, like, for example, using PET scans, positron emission tomography scans. Do you see the value of using those with adults to help?
Yeah, I see the value of using PET scans in everybody. PETs or SPECT scans. Dr. Chigani, the child neurologist, he was up in Michigan, and he's a brilliant child neurologist. He did a long ago, he's done many studies on PET scans. He's an expert. And he did a study many, many years ago identifying an area of a seizure focus in infants who had a very dangerous form of epilepsy. And they were successfully then able to do seizure surgery, and they were developmentally fine after that. They saw nothing on the MRIs. So that was a massive breakthrough. He did an early study with PANDAS, doing PET scans, finding an abnormality, giving IVIG, and seeing the abnormality go away.
On the PET scan?
On the PET scans, right.
Wow.
So PET scans look at metabolism, like glucose use, like the function as opposed to structure. And they're very valuable in this condition.
So, in thinking ahead a little bit, what kind of research would you like to see being done on adults? There's very little out there on adults.
I think we need to do the kind of research. I've said this pretty much all along. We need to act like the POG group, and I don't even know what that's called in adults, but the oncology groups, right? So you can't do nothing anymore. Like you can't just say, well, no, watch this natural history, because I think it's unethical. There's plenty of studies out there that IVIG helps, that tonsillectomy helps, that IV steroids help, that Rituxan helps, that plasmapheresis helps, that methotrexate helps, ibuprofen helps. What helps the most? Like, what's the right recipe? And to do that, you need a homogeneous group of patients, like, say, people who presented within 6 months, and they have strep in their tonsils, and we're going to do a tonsillectomy, and one group we're going to monitor and see if they get better, and one group we're going to give IVIG to and see if they get more better, say. That's an example of one group. Like, do you take another group and do plasmapheresis and see what happens with them? Do you take a third group and give them Rituxan and see what happens to them? It's almost like you have to study them longer, though. So it's like the early NIH studied them for 6 months. I've seen some of those patients that were in that study who've relapsed later, like years later. So is this something that's going to come back later? It could.
So you really do have to follow them.
You have to follow people long term. If you're going to do a research study, you have to follow. Look at like the cancer. They have 1 year survival, 5 years survival, 10 year. They don't get like, oh, you're cancer free. See you. Bye.
Oh, interesting.
You have to follow
comparison.
people, and you have to follow people and probably their children.
Any other research that you'd like to see?
We're doing a lot of research on tonsillectomy. We've done a lot. We published a really important study in 2015 in clinical investigation that looked at the abnormal types of immune markers and the tonsils in children with PANDAS versus children who got their tonsils out for just strep. And the tonsils just are not healthy. There's just no other way of looking at it. And they had very different bacteria, much more what we would consider immunobacteria, bacteria that you would find in an immunocompromised person.
Ah, okay.
And in fact, the first several times we got that back, I was like, well, why does that person have Pseudomonas in their tonsils? It's healthy, like 10-year-old, or serratia or actinomyces, or MRSA. They must have some immune disease, but no, they didn't. Once the tonsils come out, they would be fine.
So did you see these types of infections early in your career, or do you think there's a lot more infections that are people are exposed to now?
I think, well, the best way to describe it is I think it's different, right? So if you look back on what did strep cause in the early 1900s? It caused Sydenham's chorea, caused rheumatic heart disease. And when I was in pediatric training, I'm going to say 85 to 88, we saw a lot of post-infectious stuff from strep. It was mostly post-infectious kidney disease, nephritis, or something called the Henoch-Schönlein purpura, where it would affect the colon and there'd be those purple spots on the legs.
Uh-huh.
We didn't see rheumatic heart fever, just didn't see it, didn't affect the heart. And when I first started treating these kids, well, the first, I'm going to say 100 kids or so, I sent them all to cardiologists. And so the cardiologists were like, look, stop sending us these patients. They don't have heart disease. And they actually don't have the anti-CHO antibody, which is associated with the heart disease at the strep. So if they have chorea, I still send them to the cardiologist.
So there's still a lot of rheumatic fever in third world countries.
There's a lot of rheumatic fever in Europe.
So is that a different type of
Turkey and
strep?
third world countries? Well, every year, I know Dr. Pasternak talks about this a lot. Every year, the strep changes a little bit. The M proteins change, and it maybe is triggering a different immune reaction or to a different part of the body. So that's one big mystery. I think the other thing is, where did this Lyme disease come from?
Yeah.
We saw a lot. We saw Lyme disease, I'm going to say, in the soldiers coming back in the early 90s from Germany. Germany had bad Lyme disease then.
Oh, I didn't know that.
And we knew about it. It wasn't like we didn't know about it. Mm-hmm. Bartonella was identified in the early 1900s. I
didn't know that either.
I mean, why didn't it cause all this stuff then? Or did it and it wasn't diagnosed? Mm-hmm. But one thing I can say for sure is I have been looking at people's skin now for 20 years. Like I'm a dermatologist, and they're is there any evidence of scarlet fever? I'm seeing if there's sandpapery rashes, looking at their fingers and toes. Is there any peeling, which you see with strep? Or other things that can cause autoimmune encephalitis, like lupus. You're looking at skin. We're looking at skin all the time. And I really feel like it's only in the last maybe 8 to 10 years that I started to see all this Bartonella striae, these big red lash-like lines across the back. At the beginning, I was like, what on earth is this? It's very, very distinct. And I think most people don't know about it. I didn't know about it when I first started seeing it. Mm-hmm. And I think most of the time when they go to a primary doctor or someone who also doesn't know about it, they say, it's growing. It's from stretch marks from growing.
Right.
But if you look at a 17-year-old boy who's got these big red horizontal lines across their back, the teenage boys are running around without their shirts on all the time. Wouldn't we have seen that all the time?
Yeah.
But one thing I would say about these weird red marks, and anyone can Google them, just Google images for striae with Bartonella, is that I've not ever seen them in a little kid who hasn't grown. So I think your body has to expand because it affects the dermis. It's the layer of skin under the epidermis. I think your skin has to stretch for it to become apparent.
So is it not usually seen in very young children?
I've never seen a Bartonella striae in little kids who haven't grown yet.
Okay.
Not once.
Very interesting.
But I have seen little kids with Bartonella.
That's been identified through
that's
some
been
kind of a
surely
blood test.
identified and treated, and they've gotten better. Mm-hmm. But I've never seen the stretch marks.
Yeah. All right, so let's see. Are there concerns that you have with adults that you don't have with children?
Yeah, well, the danger, because they're not under someone else's roof.
Yeah, that pretty much sums it up, I think.
Yeah.
And
And they don't have as much time to fix their life.
Yeah. So, given the complexity of some adult cases, their need for them to work with other specialists.
I think we need to not be referring so much as collaborating. I think that is a problem, right? It's like, I'll refer you there, and I'm not responsible for you anymore until you come back. And what we need to be doing is collaborating.
So, what kind of a form could that take?
I think it should take a practice where, or a center, or however you want to describe it, where, everyone, the people involved in caring for the family, including the person who's ill, have, a same mission, perhaps different ideas. I hope so, because otherwise you don't learn anything, and can bring, everything together, and you can give your best of everything and agree upon it so everyone knows what's going on. One of the problems that I see is that, I'm going to my functional medicine doctor, and they are going to give me supplements, and that's what we're going to try for now. And we're going to wait on the medical end of it. That's not a good idea. It's not. Mm-hmm. Or I'm talking to my therapist who, they don't really know whether I have this or I don't have this. Well, if everyone was in the same place and you could meet once a day, I think we would come to agreement.
Absolutely.
We've been doing that for decades.
Right.
As long as I've been in medicine, sometimes there were nasty fights, arguments, but you could listen to the other person. Doctors go to school to learn how to solve problems, not to win the day. Right.
That's such a good point. That, as we frequently hear, everybody's working in a silo, and let's bring them all
Everyone's
together.
working in a silo.
And
even people in medical centers are working in silos.
Interesting. The other concern is going to the functional medicine doctor or the therapist or, the rheumatologist or what have you, that the onus is on the patient who's already not doing well in communicating about what the functional medicine doctor said to the and communicating that to the neurologist.
That would be like me communicating to the guy who's going to fix my car about what the guy who picked it up by the side of the road said was wrong with it. I don't know. It's not working.
Yeah, exactly. That's a great example.
Yeah, I don't
Whereas
know.
if you're all together, I don't know. When is that going to happen? Yeah. Okay.
And I honestly don't have a problem with, you don't want to control everything. You can't control everything. And you want people to feel supported. And I have a bunch of colleagues, and we all have each other's phones. We text each other. And that works pretty well. Not ideally.
With children, you've got the parents to take care of them. Hopefully.
And you also have to take care of the parents.
That's also very
and
important.
the other children who are now hiding under the bed.
It is very complicated, isn't it?
The whole family is ill. The whole family is sick. The grandparents are involved. There's sometimes a child living at the grandparents, another child living at the grandparents. They're split up. I have a couple right now that the mother's taking some of the kids, the father's taking the sick child.
So as a neurologist in private practice, do you, what can you do for the family or for the extended family? These are such complex cases. I'm just wondering, as an individual practitioner, what do you do?
Educate them. And tell them if things get out of control, call 911. Don't hide this. Mm-hmm. You need help. And actually, that often puts a lid on things too. If a person feels out of control and help comes, it gives them a little ceiling. They feel a little safer because they feel very unsafe themselves. Mm-hmm. So that's not like it's a cruel thing to do when someone's having a crisis. Some people need to be admitted to be stabilized before they can be treated in a psychiatric hospital.
So one thing that we have, the Alex Manful Fund has worked on and off, is to develop I think a workbook might be the best way of describing it, for young adults who are leaving the home and maybe going out to college or going to having a gap year or going to work or whatever, but some kind of a workbook with guidance for them about how to make that transition successful from the home where the parents were helping you with everything, reminding you of doctor appointments and making sure you had nutritious meals and took your drugs and watched you, versus going to college where you won't have that. Do you have any advice to parents?
Yeah, I think start earlier. So make them do their own stuff before they leave your house. But the parents are very involved. I mean, there's parents picking out their classes for them. I mean, writing their papers for them. It's, and I understand why they're doing it. They just want them to get to the finish line,
Yeah.
so they can move on. I totally understand it. But you made one comment that was interesting. Make sure they take their drugs. When I went to college, nobody was on drugs. Nobody was on medicine.
That is really interesting.
Yeah.
I would completely agree. What is going on?
Well, one thing that I think is an issue is the fact that they stopped taking tonsils out. I've been talking about that for a long time. They took out 1.4 million tonsils in 1959. That was the peak year. Took out like 400,000 in 1980. It's actually a big meeting in Miami with the pediatric ENT docs about whether or not PANDAS is a whole separate indication for tonsillectomy, independent of strep.
When was that?
It's happening in September.
Ah, okay.
Yeah, I'm going down to that.
What's kind of interesting about our conversation today is that we're going to talk about adults, but it's really impossible not to talk about children as well. And so I think that just sort of underscores the problem in looking at this as a pediatric disorder versus a disorder that adults may or may not have. We just should be looking at this as a disorder that, like many disorders, it surfaces differently in children than it does in adults.
I'll give you the best example of that. Huntington's disease, right? Everyone thinks about Huntington's disease as being something that happens when you're 7 years old and you lose all your motor function, and it's you're going to die from Huntington's. It's chromosome 4. It's got a clear genetic marker, right? Children present with Huntington's too.
Due to the chromosomal?
They have the same chromosome. They have Huntington's. The same
and it's
chromosome.
Presenting in children?
They have seizures.
That's how it presents in children?
Yes.
I had no idea. Very interesting.
Yes. So it can look, it's totally different. It's the same disease.
So knowing that about Huntington's, what advice do we have for people who are working in this area, whatever we want to call it?
Take a family history. Yeah. Take a really, really good family history. And if you find out that the maternal uncle committed suicide at age 35, ask a little bit more about him. Don't just write down, and then you'll find out maybe he was out of school for 2 years when he was 13, and that he had OCD, and that he couldn't leave the house, or that he couldn't drive. There's many of these other family members have had the same thing.
So it's really important to see those as symptoms and look for any underlying infections that may or may not still be there, and what's going on in the immune system.
The concept of treating this condition is very, very simplistic. Identify the trigger. If you can eliminate it, eliminate it. If you can't, you can't. And then move on by trying to change the immune reaction to it. Whether it's IV steroids, IVIG, Rituxan, plasmapheresis, methotrexate, something that hasn't been invented yet. just keep your mind open. You have to dig deep for the infection.
Well, as I've said before, I think you have to be curious as a doctor, and you have to persevere. You have those qualities. Not everyone does.
Well, not a lot of people have the ability to do that anymore. I was just reading something, watched a little video on Instagram, I think yesterday, and it was a doctor, and there was a private equity person on one side and an insurance person on the other side, administrative, and he was like, I make the decisions here. I don't just give suggestions. I make the decisions. I want to make the decisions. I don't want to just give you suggestions. And he throws his hands up and walks away. I think that a lot of doctors in the hospitals are experiencing the same thing right now. They cannot make the decisions.
Yeah, not good. All right, Beth, thank you very much.
Thank you.
This concludes episode 4 of Untangling Pandas and Pans. Thank you for listening. For more information about Pandas and Pans and the Alex Manfull Fund, please visit thealexmanfullfund.org. The content in this podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.